Improving outcomes in perinatal substance use disorder. Substance use disorder is defined as a treatable chronic disease involving problematic use of a substance which results in impairment of health, social function, and control. Individuals with substance use disorder continue to use substances despite harmful consequences. SUDs can be mild or severe and can affect anyone regardless of race, age, sex, gender, social class, or income level. SUDs can affect all aspects of a person's life, including work, school, family, and friends. Based on a 2020 National Survey of Drug Use and Health, 40.3 million Americans aged 12 and older suffered from a substance use disorder during the past year. It's estimated that more than 10 million people in the U.S. misused opioids in 2019 alone. Drug overdose deaths, especially those involving synthetic opioids like fentanyl, reached record highs in 2020 and 2021, potentially linked to additional social, financial, and health stressors resulting from the COVID-19 pandemic. The perinatal patient population is included in these statistics. The CDC reports the number of pregnant women with opioid use disorders presenting for labor and delivery has more than quadrupled from 1999 to 2014. The 2019 past month use rates for pregnant women reported by the Substance Abuse and Mental Health Services Administration are shown here. These statistics were reported pre-COVID-19 pandemic. However, SAMHSA acknowledges that reported national trends do not match national averages. It is thought that national trends in pregnancy-associated overdose mortality are underrepresented in current reported statistics. Opioid use in pregnancy. The CDC's 2019 self-reported data on opioid use in pregnancy is depicted here. The number of women presenting for delivery with an opioid-related diagnosis increased 131% from 2010 to 2017. 2018 data regarding newborns born with neonatal abstinence syndrome is depicted here. The number of babies diagnosed with NAS increased in this country by 82% between 2010 and 2017, with increases across all regions and demographic groups. Polysubstance use in pregnancy. Substance use disorder can apply to any variety of prescribed and illicit drugs, including alcohol, inhalants, opioids, sedatives, anxiolytics, stimulants, nicotine, hallucinogens, and hypnotics. Polysubstance use is common in pregnancy. The 2020 Morbidity and Mortality Weekly Report, published by CDC scientists, reported that 10% of pregnant women reported current alcohol use of at least one drink within the past 30 days. 40% of those women who reported current alcohol use also reported current use of one or more other substances, the most common being tobacco and marijuana. A 2020 study found that 74% of pregnant women who reported marijuana use before and during pregnancy also used tobacco during pregnancy. A 2017 study found that greater than 50% of pregnant women who used opioids during pregnancy for non-medical reasons reported drinking more than 5 alcoholic drinks per day during a 1-month period. A 2015 study found that pregnant women who were prescribed opioid medication were more likely to smoke tobacco than non-opioid users. Perinatal cannabis use. The effects of intrauterine and neonatal exposure to alcohol and tobacco are well known. Cannabis exposure is new terrain. Global usage is rising as decriminalization and medical application of marijuana increases. The psychoactive component of cannabis delta-9, tetrahydrocannabinol, or THC, has steadily increased over the years. The implications of cannabis use for the mother-placenta-fetus triad are unknown. Canada legalized recreational marijuana use at the national level in 2018. As a result, antenatal exposure, lactation exposure, and long-term neurodevelopment outcomes in children have become widely researched. The outcomes of gestational cannabis use is still widely unknown. However, the following have been associated or suggested with its use in the perinatal population. Increased risk of other SUD during pregnancy, impaired placental blood flow, increased risk for SGA, maternal fatty liver, obesity, insulin resistance, increased risk of GDM, increased risk of childhood and adolescent depression, and ADHD disorders. Another large study in Canada evaluated 1.3 million births across 12 different provinces and territories between 2012 and 2019. Their study emphasized the urgent need to understand how cannabis use affects pregnancy. They found an increased likelihood for preterm birth, low birth weight, SGA, and major congenital anomalies with cannabis-exposed fetuses, with females showing an increased susceptibility. The stigmatization of SUDs in pregnancy. The problem of substance use disorder in pregnancy is complicated by bias and stigmatization by healthcare professionals and the public. Research has found that non-pregnant people are generally perceived as having a biologically derived addiction. This allows blame to be shifted away from an individual's character with an understanding that addiction is a biological disorder. Pregnant women are not viewed the same. They are viewed as having a biological and moral basis for addiction. This means we tend to view pregnant women as having both a biological fault, driving them to substance use, as well as a moral fault, causing an inability to avoid substance use. Stigmatization of pregnant women with SUDs promotes a negative self-perception, making them less likely to seek help. SUDs can be viewed as a personal weakness. This promotes a self-belief that an individual doesn't deserve care. Despite the tremendous stigmatization associated with SUD in pregnancy, most pregnant people reduce or stop using when they realize they are pregnant. The stigma surrounding SUDs in pregnancy frames addiction as a personal choice, a moral deficiency, and a lack of willpower. This enhances avoidance of healthcare services and significantly contributes to negative outcomes for mother and child. SUDs in rural communities. Substance use disorders are further complicated for women living in rural communities. Finding and accessing treatment centers for SUDs is more challenging, while access to care is further complicated by a lack of anonymity. Boundaries between medical settings and the community may be less defined in rural settings. Accessibility and acceptability are significant barriers to health care, exacerbated by the rural setting. Stigmatization of pregnant women with SUDs continues into treatment. Medical treatment for opioid use disorders can be viewed as temporary solutions, diminishing a pregnant woman's management efforts. Pregnant women experience stigma which inhibits appropriate care. The stigma continues even when they are actively seeking care. As a result, the perinatal patient population is extremely limited by the social stigma surrounding SUD. Outcomes for the children. Expansive research was conducted on federal policy and the effects on parents and children by SUDs. National data collected between 2005 to 2017 resulted in the following data. Collaboration between multiple disciplines, including health and social services, will potentially reduce costs associated with SUD and improve outcomes for the parent-child dyad. How can we improve patient outcomes? The first step to improve care is to understand why. Research has shown significant prevalence of past trauma among women with SUD. Parenting women are among the fastest-growing populations in the opioid substance disorder epidemic. Healthcare professionals have many opportunities during the perinatal period to assess and engage with these women. Recognizing the connection between trauma and substance use disorder destigmatizes common perceptions of pregnant women with SUD. Trauma-informed care is the recommended approach. According to Dr. Bernadette Chiarelli, MD, the essence of trauma-informed care is changing the perspective of the patient's experience by asking what has happened to you, instead of what is wrong with you. Screening recommendations. The opportunity to screen patients for substance use creates an opportunity for the nurse or provider to use person-centered language that emphasizes the individual instead of the diagnosis, non-stigmatizing language, and non-judgmental communication to meet patient needs. Universal verbal screening should be done consistently and in a non-discriminating way, and is recommended by several guiding organizations such as the World Health Organization, the Substance Abuse and Mental Health Services Administration, the American Psychiatric Association, and the American College of Obstetrics and Gynecology. Strategies to improve outcomes for these patients include trauma-informed care when appropriate, focus on the person, not the diagnosis, advocate for solutions to negative outcomes, including counseling and treatment, implement protocols to support families, promote parental bonding, and enhance capacity of parents to confidently care for their children. To summarize, there are several strategies that have been shown to help improve outcomes for perinatal patients with substance use disorder. These include increasing accessibility to evidence-based substance use treatment, promoting a supportive, non-judgmental healthcare environment free from stigmatization, blame, and shame. Provide support that promotes parental and child development through education, resources, and follow-up. Multidisciplinary teams working together to provide interprofessional holistic care, connecting patients with resources to support social and psychological well-being. Despite the barriers experienced by the perinatal patient population with substance use disorder, pregnancy provides a unique opportunity to interact with these patients when they are most intrinsically motivated to get help. Integrated, comprehensive, patient-centered care may significantly improve long-term health outcomes. References used for this presentation are provided here. Thank you.